Good afternoon, everybody. I'm Courtney Gallop. I'm broadcasting here from Nags Head, and I'm an officer with the League of Women Voters of Dare County, and I'm in charge of the Health Concerns Committee. Tonight, we'll be discussing urology. And for those of you who are not aware, urology is defined as a field of medical study pertaining to the human urinary tract and the male reproductive tract. As with everything, there are several subspecialties, including female urology, male infertility, neuroneurology, pediatric neurology, and urologic oncology. Tonight, we are very pleased, very honored, and very excited to host a brand new urology expert and doctor with the Outer Banks Hospital. We have with us tonight Dr. Urologist Amanda Pettibone-Pond, MD. Dr. Pettibone-Pond is a graduate of St. George's University School of Medicine in Grenada, West Indies. She completed her urology residency at the University of Tennessee in 2016. She has worked at the Indiana University School of Medicine affiliated community practice, and she was partnered there with 4 other urologists managing men and women's urological health. She is board certified in urology. Dr. Pettibone-Pond started seeing patients in our community June 16th, 2020. She works closely with colleagues at the Outer Banks Hospital and is relying on the expertise of Vidant Medical Center in Greenville, which is the region's only academic medical center. There's many of you joining us tonight, and we are absolutely thrilled and excited. We're going to have a presentation from Dr. Pettibone-Pond on the top 3 urological issues that she's currently seeing in the Outer Banks. And she's been so kind to share with us the latest and greatest in medications and treatments for those issues. We are going to not take too much of the doctor's time tonight. We're going to keep questions focused right on the topic. We are going to be screening questions, and we're not going to be entertaining questions about personal medical histories, personal diagnoses, personal medications, or anything that specific. So we're going to ask everyone to try and stay with the topic so we can get as many questions in as possible. Dr. Pond, I turn it over to you, ma'am.
Thank you. And thanks everyone for tuning in. This is my first Zoom presentation, so bear with me. I just want to say it's been great being out in the Outer Banks. My family and I, we feel very fortunate to be out here. We've been so welcomed by all of our patients and coworkers, and hopefully we've saved a few people the drive up to Virginia Beach and Greenville. But it's been a pleasure, and we've been busy and hopefully taking care of people here in the Outer Banks and the surrounding areas. So I just have a couple topics that I see regularly for men and women. The first topic that I was asked to talk about the challenges, and I wasn't sure if that was for me or the patient, but one of my challenges in urology is to help patients find the bathroom or try to stay out of it or get there soon enough. So both men and women have issues with having to pee too frequently, too urgently. I have a lot of patients who, it's a day-to-day struggle. They feel bound to their homes. They feel like they can't drive somewhere without knowing where the bathrooms are. Oftentimes they're now having to wear pads or pull-ups, and it really affects their daily lives, their quality of life. It's a source of embarrassment for many people as well. And it's a problem shared by men and women. And so when I see men or women, I'm one of those people who believes that our behaviors make a lot of difference in our lifestyles too. So the first thing I talk to people about in the office is simple behaviors like, well, what do you drink during the day? Because a lot of things that we drink are caffeinated or carbonated, and those are bladder irritants. And most people don't think about the bladder being irritated. They know that when their stomach is irritated, that they get heartburn or they throw up, and when their bowels are irritated, we know what happens. Another potential for embarrassment. But when your bladder's irritated, it tells your brain that you need to pee. And a lot of people don't make that association. So things that commonly irritate the bladder are caffeine, carbonation, anything acidic, spicy foods, alcohol, chocolate, unfortunately, and tobacco. And so cutting back on these things, often people don't drink any water. I ask, what do you drink? And they go from coffee to soft drinks to tea. And all of those things are just constantly irritating the bladder. And again, when the bladder is irritated, it tells the brain to go pee to get rid of whatever's irritating it. And so cutting back on a lot of these things that irritate the bladder can really make a big difference. And in some cases, more difference than the medications. And there's no side effects from changing behaviors, whereas these medications often have a lot of side effects. So that's really where I start. And for some people, like I said, it helps more than a medication. So I like to really sit down and talk to people about those types of behaviors. And as we age, our bladder becomes more sensitive, just like our stomach becomes more sensitive. When our stomach, we go, oh, I can't eat spicy food anymore because it gives me heartburn. Well, the bladder is the same way. And things that didn't used to bother us and irritate us now can be very irritating and can worsen any urinary problem that we have. Another thing that I like to talk to patients about is their constipation, because constipation, your bowels are down there with your bladder, they're controlled by the same nerves, and a lot of people that I see are very constipated. So I like to help them, to talk to them about that, because that can affect the bladder as well. Once we get beyond those basic things, I talk to people about their medical problems. Various medical problems can cause you to pee more frequently and more urgently, especially conditions like diabetes. If it's not well controlled, you're going to pee more frequently. Cardiac conditions, in people whose hearts maybe don't pump as well, they get some fluid backup and their body tries to get rid of that fluid by producing its own diuretic. And so that can cause some urinary frequency. And various neurologic conditions can cause a lot of frequency and urgency of urination, like Parkinson's or multiple sclerosis. Even people with some spinal issues, spinal stenosis or a pinched disc, or various issues with the spine. And so kind of managing expectations too with people who have these conditions, and letting them know that these can cause it and that may not be something that a urologist can necessarily fix. And medications, people who are on diuretics for cardiac conditions or various reasons, obviously that's going to cause a lot of urinary issues as well. And speaking with just women, women tend to have more leaking than men. Certainly men can have some incontinence as well, but for women, I like to try to figure out what causes them to leak. Is it urgency? Is it sneezing or coughing? Women who have frequency and urgency of urination, meaning I've got to go now, and who get up at night, we call that those constellation of symptoms: overactive bladder, I pee every hour, whether I've had anything to drink or not. I get a sudden compelling urge to urinate that I can't hold, or I'm in trouble on the way to the bathroom, and I get up frequently at night. Those symptoms we generally call overactive bladder. And for those, again, the behavioral changes are very important. Otherwise, nothing I do will help. If the behavioral modifications aren't cutting it, There are a number of medications that we try. There's many of them. One of the newer ones you've probably all seen an advertisement for called Myrbetriq. The nice thing about the Myrbetriq is the side effect profile. Most of the older medications work by altering muscle contraction. They're called anticholinergics, and they can cause some dry mouth and constipation, which can be really bothersome to people. Myrbetriq works through it's a beta agonist, so the side effect profile is much better, and a lot of people find that to work better too. You can use a combination of those medications, one of each, if one or the other isn't good. But if that still isn't good enough, generally I'll take a quick peek in the bladder, something called cystoscopy that's done here in the office. Make sure there's nothing in the bladder that's irritating it. And then we move on to what's called third line therapy, which both report about a 50% improvement in the urgency, the incontinence frequency. One is we do Botox here in the office. So Botox relaxes muscle wherever we use it. In the bladder, it relaxes the bladder muscle, so it's not constantly contracting and doing its own thing. The benefit of that is it's done here in the office, no anesthesia, but Botox, like anywhere we do it, isn't permanent. So it's done about every 4 to 6 weeks. But then you don't have to worry about medications, and 4 to 6 months, 4 to 6 months. So that's a good option. And then another option for what we call refractory overactive bladder is something called an InterStim, or sacral neuromodulation. And it's just a little, I compare it to a heart pacemaker. Most people know what a cardiac pacemaker does. It regulates the electrical activity of the heart, slows it down, makes it more regular. The InterStim device does the same thing. For people who have underactive bladder, it increases the nerve stimulation to the brain and tells your bladder to contract. For people with overactive bladder, the bladder's giving the brain too many signals, it slows that down. And so I find that works really well for women. What I like most about that is there's a trial period. So it is a surgical procedure, minor surgical procedure. It's outpatient. We put a little lead next to the third sacral nerve, and you get to try it out for 2 weeks. And if you don't notice an improvement in 2 weeks' time, then we just take it out. If you do, there's a little battery that goes under the skin, and that battery lasts for 5 years, and you don't have to worry about it. So I really like that as an option, especially for younger women, because 6 months goes really fast, and doing Botox in the bladder every 6 months for decades would probably be very wearing on someone. That InterStim device is also indicated for women who have, well, men and women who have urinary retention and bowel incontinence. So bowel incontinence is something people don't really like to talk much about, but that device helps with that as well. And so those are kind of the overactive bladder treatments, behaviors, medication. We also have a fabulous pelvic floor physical therapist on the beach who is trained in these matters as well. So that, and then the third line therapy, the Botox and the InterStim. For the stress incontinence in women, again, the leaking with laughing, sneezing, exercise, that's generally over time, our pelvic floor gets a little weak and those muscles just can't get together and contract to hold things off. And so the options for that, again, still the cutting out caffeine, because that can make it much worse. But the pelvic floor physical therapy, as I mentioned, and I refer people there frequently for that problem, is really the only treatment that gets at the problem, which is a weakened pelvic floor. Beyond that, there are incontinence pessaries that we can put in the vagina that actually helps close off the flow of urine a little bit. And then I do a urethral sling, which is a little piece of tape, almost. It's the mesh piece of tape that goes in surgically under the skin and helps you hold your urine as well. So that's for women. For men, I generally am addressing if they're over 50 and they're spending a lot of time in the bathroom and frequency and urgency. I generally target their prostate. Obviously, women don't have one, but for men, generally the prostate starts to be the problem. And so there's really only 2 classes of medications to try for that. And when we've exhausted those, there are procedures that can be done for that as well. There's procedures that are done in the operating room, and then here that I do both in the operating room and in the office. One of the newer things is something called a Urolift. So just a diagram of male anatomy here. As we age, the prostate starts to block the flow. And so men have some hesitancy, some weak stream. They feel like they don't empty. They may have some dribbling, frequency, urgency, getting up at night. And a lot of times it's because that prostate's blocking the flow of urine. So the procedures to help the prostate are basically, how do we open this channel? And there's a number of ways that can be done. One of the newest that's minimally invasive is this Urolift. And instead of shaving it or using a laser to laser it out, or there's vapor, you can vaporize it. What the Urolift does is it clips it out of the way. So we have a channel like this that's closed off, and then we can just put some clips in and kind of clip it out of the way. It's likened to like a curtain tie back. And that's done here in the office, usually with some Valium and some nitrous, and it takes about 10 minutes. And most men don't need to go home with a catheter, whereas if we do the procedure in the operating room, they do. So the benefit of this is that it's minimally invasive. It's done in the office. Men don't have a catheter, and the return to normal symptoms is much sooner, and it doesn't affect sexual function. A lot of the medications that we treat BPA, enlarged prostate, have a lot of sexual functions, sexual side effects. And so this has none. And oftentimes I stop medications once we do something for the prostate. Some people like to stay on medications because they're a little nervous about having a procedure done, but some people these days, everybody feels like they're on too many, or they don't want to take any more medication. And so this is a great option for men who don't really want to commit to a surgery, but like to come off of their medication. So I think that that's really great. And I really think that that's changing how I treat an enlarged prostate. But again, there's a surgical procedure that shaves that tissue out, because not everybody will be a candidate for the Urolift. But oftentimes getting that prostate out of the way really helps alleviate a lot of men's problems. But men can have overactive bladder too, and certainly sometimes they need some of those medications, or even an InterStim as well. So that was just my first topic. The second thing I see a lot of here are kidney stones. And people always seem to think it's the water. Everywhere I've been, it's the water. And that maybe doesn't come up in our literature much as the water. But people say, what causes kidney stones? How do I prevent them? Really, the number 1 and 2 cause of kidney stones are hydration and genetics. People, again, who don't drink a lot of water, and that urine gets very concentrated, and those crystals form, and they form a stone. So not drinking enough water is like the number 1, 2, and 3. And unfortunately, genetics is a strong risk factor as well. But also, it's like everything else, diet and other medical problems can put us at risk. Dietary, people who eat a lot of salt, people who eat a lot of animal protein, People with various medical conditions, diabetes, obesity, high blood pressure are the more common ones. People with gout can also get kidney stones. People with parathyroid gland issues, which isn't as common, but certainly can be a cause. Various medications. There's a Topamax is a migraine medication that commonly can cause some kidney stones. So prevention is really fluids, and that excludes tea and dark soft drinks. Those have high phosphoric acid and they can increase the risk. So really water's the best, or anything clear. Watching your salt and your animal protein. These days, a lot of people are on, the high protein diets, Atkins or keto, and they may be good for weight loss, but they're not good for kidney stones. And people think they can't eat calcium, calcium stones, I can't eat calcium, but you actually need calcium in the diet. There's an inverse relationship between how much calcium we eat and our stone form. So calcium is actually good for that. But getting to treatment, some people say, when do I need to have this treated? Most of us walking around probably have a kidney stone and don't even know it. It's when it tries to pass that the flow of urine gets blocked and you have that terrible pain, nausea, sweating kind of feeling. Here at the Outer Banks, one advantage of not having a urologist for a while is we get new equipment. And so we are to get one of the newest, greatest lasers. It hasn't arrived yet, but we are getting a brand new laser here. It's instead of a holmium laser, it's a thulium laser, which probably doesn't mean much to a lot of you. But it just breaks up the stone a lot faster into smaller fragments. So it shortens the time of surgery, so less time under anesthesia. And we can do bigger stones that way. Traditionally, large stones, which we say are over 2 centimeters, we kind of go in through the back. It's a slightly invasive procedure, usually involves an overnight stay. But with the advances in lasers, now we can tackle a lot of those big stones that way rather than having to do something more invasive. Another thing that we're working on getting are disposable scopes to take care of that. Again, most people are asleep and they don't know what kind of scope we use, but the disposable scopes are great because it really minimizes the infection rate because you get a brand new scope every time. So generally those are taken care of with a laser, but we also have the shockwave lithotripsy out here if you want something less invasive. But we do all of that here. So we do a lot of kidney stones, and again, hopefully we'll be getting an awesome laser here soon. And I've seen some questions. Should I be answering those as we go or wait till the end, or what should I do about that? I'll just keep going. Okay. And then the last thing that I deal with a lot, which is more for the men, but most of the women know men, and it's an important thing, and that is prostate cancer. The United States Preventative Task Force put out some recommendations a few years ago. Oh, well, we don't even need to screen men for prostate cancer because nobody dies of it. Prostate cancer is the second most common cause of, the second most common cancer in men, and the second what they die of, the number 2 that they die of too. So lots of men still die of prostate cancer. And sometimes it's clear on who needs to be screened. The American Urologic Association recommends screening the average population from age 55 to 69. For African Americans and those who've had a family history, we generally start at age 40. So prostate cancer screening usually involves a blood test called a PSA and a digital rectal exam, so a prostate exam. And if that PSA is elevated, we generally do a biopsy. That's done here in the office. Unfortunately, those are treated with, well, there's various options for treatment. The surgical option is having it removed robotically, which we don't have here at the beach, but there's plenty of people close by who do those. And then radiation, and we do have radiation here locally. But all men should be screened, and plenty of men, unfortunately, still die of prostate cancer. If men are over 69, that doesn't mean they don't need to be screened. Generally, if they're a healthy 70-year-old or even 80-year-old, they can still be screened. But everyone should be screened, and that's usually done through primary care. And then if there's something abnormal, then they'll send them to me. But we do the prostate biopsies here in the office. And if they need radiation, that's done out here. Otherwise, I refer them to have their prostate removed, but then they can resume care here, and I watch them after surgery. So those are the three most common things that I see in my office. I see lots of other things as well, but those are kind of the most common, and I hope something I said was interesting or educational.
Dr. Pond?
Yes.
Thank you. I mean, I have learned a tremendous amount already. You have covered the three top visit concerns, and we've covered a bunch of new treatments and new drugs. So I'm going to start off the question ball rolling. And the question I have for you is, can you tell us, well, lost my place. Dr. Pond, I'm here. Dr. Pond, can you tell us about your training in Grenada and how that might differ from, or is it the same as schooling, US schooling?
Yeah, so I had a very non-traditional path. I didn't like go to college and then go to med school. I didn't even know I wanted to go to med school. So I did a lot of other things, and I went to grad school, and I started teaching anatomy and physiology, and I was 27, I think, when I decided I wanted to go to med school. And by the time I did, I didn't know anybody who was applying to med school, and I had no idea where to apply and how to apply. And so I ended up going there, and I got to spend my first year in England, and it's all based on American curriculum. So I did a year in England, and then my second year was Grenada, and then my clinical years I did it in New York. So half of my med school was actually in New York. So I got to spend some time in Manhattan and Brooklyn, and so it was a big adventure. Like I said, not traditional, but it was all, I mean, we all have to take the same board exams, and it's all the same, really. So
that is,
I mean, it was obviously unique, but the curriculum and everything was American, the same as any American medical school.
Excellent. Very, very enlightening. So we've had a question pertaining to kidney stones. And the question is, doctor, how do you decide which treatment to use for kidney stones? And how do you decide when they should simply be allowed to pass at home?
That's a great question. So stones that are so there's something called shockwave lithotripsy, which is all done from the outside, where you use shock waves to kind of pound the stone about 3,000 times is the maximum amount. And then there's the laser, where we go up from the inside, send a laser up and break it up that way. So generally, if they're not a large, if it's just a stone in the kidney, meaning it's just there, it's not causing any problems, it's under 2 centimeters, I think that the shockwave lithotripsy is good, because again, it's all done on the inside. You don't have to have stents. People who've never had a stent don't know what a stent is like, but if there's anybody out there who's had a stent, they're a tube that goes between the kidney and the bladder just to help everything drain. And they can be very bothersome because the body tries to get rid of them. And that process causes a lot of cramping, which causes some discomfort. So I actually have a diagram here. So when the stone is just hanging out in the kidney and it's not causing any problem, I think the shockwave lithotripsy, and there's only one of them. If you have a whole bunch, the shockwave lithotripsy won't work. But if you have one stone, say it's a 5 or 6 millimeter hanging out, not causing problems, but you're going on vacation in 2 months and you don't want to worry about passing it before you go, shockwave lithotripsy is a great way to go. If it's stuck in the ureter, this tube here, then you've got the pelvis in the way, and that shockwave lithotripsy just isn't as good. So that's generally when I'll go in with the scope and the laser and break that up. And you can do laser for the stuff in the kidney as well. And there's what we call the stone free rate is much better when I go in with a scope and a laser, because I have a lot of control over whether that stone gets broken up or not. Whereas with the external lithotripsy machine, you're kind of counting on that to take care of it all. So we say the stone free rate is better when I go in with the laser and I have my basket and I can see everything and I know that the stone's being broken up. But when we go up on the inside, generally we leave a stent just for the fragments and the inflammation and that sort of thing. And the stent can be very bothersome. It's just temporary, but it can be bothersome. So especially young people who have really aggressive peristalsis in the ureters, the stents can be really uncomfortable. So the shockwave lithotripsy from the outside, I would generally recommend to people who have non-obstructing stones in the kidney. Once they start blocking the flow or they get into the ureter, I'll go up with the scope and the laser.
Excellent. Thank you, Dr. Pond. Changing over to prostate. One of our viewers, a gentleman, has said that he's heard some confusion about the reliability of the good old PSA test. Can you share the current thinking concerning PSA tests?
Yeah. So I don't know a urologist who doesn't use PSA. I think PSA is still recommended for screening. Sometimes there's some ambiguity over, oh, I got a PSA of 4.2. Well, so let me backtrack. So for men in their 60s, which is the most common decade that we diagnose prostate cancer, a normal, we want that PSA to be about 4. So it's 4.2. You know, what do we do next? Do we do a biopsy? Do we watch it? Or do we do some fancy tests? But PSA is always where we start. And I don't know a urologist who doesn't use PSA. You can use percent-free PSA, and there's a 4K score, and there's a prostate health index. But in the end, they all use some form of PSA. And in the end, it's all just a statistic. There's nothing that will tell you whether you have prostate cancer or not until you have a prostate biopsy. There's even now we're using a lot more MRI, which is the only imaging test that we have that can help try to identify areas that may be suspicious, but even that you still have to have a biopsy. So I find I still use PSA, and like I said, every urologist I know uses PSA. There's other adjuncts to it that you can use if you're not certain whether or not to do a biopsy. And certainly in the initial, sometimes people have elevated PSAs and they have a negative biopsy, and that's kind of when I use some of these more specialized tests. But I think I still find that a PSA of 4, and unfortunately, I still find a whole lot of prostate cancer just using a PSA. But it's absolutely not perfect, but there's no test at this point that is. But a slowly rising PSA is generally concerning, and more in a prostate biopsy. But I still use PSA. It's definitely not the only tool in the toolbox, but I still think that it's a good place to start for screening.
Excellent. Dr. Pond, some of the new treatments, such as urethral sling and the shockwave lithotripsy and this brand new laser that is being installed at the hospital, are those are those considered experimental, or are those treatments that are covered by standard insurance and Medicare?
Yeah, there is nothing that I do that is not covered by insurance. I don't do anything experimental. I'm not that brave.
Awesome. You kind of glossed over constipation.
Mhm.
I think that's, pardon the pun, a big one for a lot
It
of
is a big
people.
one.
I think
Uh-huh.
it's a big one for a lot of people. Can you run down when to be concerned about, when to see someone like you about constipation?
Well, I am not a constipation doctor. I'm just going to say that. But a lot of people that a GI doctor is generally who you see for severe, profound constipation. But a lot of people, I struggle. I have to use Metamucil or Miralax, or I'm on a daily stool softener. But I find that a lot of us don't realize how much fiber we're supposed to get in a day. It's like nutrition 101 that we aren't aware of. But that's people, I think it's easy to say, oh yeah, just take some Miralax every day or just do this. But I like to talk to people about getting fiber in their diet. So the recommendation for fiber in your diet is 25 to 35 grams a day every day, and that's for everybody, not just people with constipation. And if you don't know how much you're supposed to have and you're not paying attention to what you're getting, chances are you're not getting enough fiber from your diet. And so I have just a general sheet of a breakdown of fiber content of various foods, and I kind of show people like things that are high fiber and remind them what the goal is and what they should get every day, and make sure they're staying really well hydrated so that they don't have a worse problem. But I find, a majority of people don't know how much they're supposed to have, and they don't know how much they're getting. And so a lot of times they can correct a lot of that by just improving their diet and hydration. But that's where I start. And again, I don't claim to be a bowel doctor. I'm a bladder doctor, but a lot of patients that I see are constipated. And so that's where I like to start with people, is just their bowels. And then once you've maxed out your dietary fiber and you're making sure you're really well hydrated, and if you're still having problems, then maybe that's when you see somebody.
Thank you, Dr. Pond. You focused a lot on hydration. We do have a question concerning caffeine. The question is, do we get a pass drinking decaf beverages, especially decaffeinated tea and herbal tea like ginger tea?
For which problem?
For bladder irritation.
Yeah, so for bladder irritation, you can drink decaf coffee, you can drink decaf tea, no problem. You can drink all, as long as it's not carbonated. Carbonation can irritate it too. I always tell people it's not like you have carbonated urine, it's just the chemicals used in the carbonation process can be irritating. But now decaf tea for stones can still have phosphoric acid. So I would, if you're a stone former, I would avoid all forms of tea. But if it's for bladder irritation, you can do decaf coffee and decaf tea.
Excellent. Dr. Pond, do you practice in any of the specialties that I listed earlier?
So I'm what you would call a general urologist. So I did not do a fellowship in any subspecialty. So I kind of see all things.
Excellent. Oh, do you see kids, or that is
Yeah.
only pediatric?
Yeah, that's generally just falls into the pediatric urology.
Okay. I'm sure you're aware of the aging demographic in this community. Do you foresee, it's huge. I mean, this is an aging community, consistent with the state and with national demographics. Do you foresee getting partners or more urologists on the beach?
I guess we'll just have to see how things go. You know, I'm still in my first year here, and we've been busy, but I think, you know, we've been able to accommodate the important stuff. And I think everybody's everywhere is booked out. No, it's not just here, and it's not just me. No matter where you go, I think there's a shortage of urologists and a shortage of a lot of primary care and subspecialists. So the answer is, I don't know. We'll see.
That's good to know that everything's blocking up, everything's full, and including urology. So we've had a question concerning urine leakage in women. And the questioner notices that women seem to leak more than men, and she wants to know, what can we do as women to tighten things up? Her words.
Yeah, so that's where I like to send women to. So a lot of that is childbirth, right? And men have their prostate, and that seems to help them hold their urine. We don't have that. And we have a very short urethra. Men's urethra is much longer than ours as well. So it's not the Kegels. A lot of us have heard about the Kegels. Kegels are great, but it's a whole pelvic floor that needs to be strengthened. And so again, that's when I'll send people over to Sarah Cox, because that's her area of expertise.
So on average, if you're thinking you're experiencing an issue, how many visits does it take to diagnose, say, overactive bladder, for example?
Yeah, overactive bladders, I mean, it's a clinical diagnosis. So there's no blood test or anything like that that can be done to diagnosis. It's just a clinical diagnosis. But generally, based on your symptoms, we make that assessment. You know, sometimes the waters get a little cloudy when someone is also having blood in the urine. So every time you come to my office, we check urine. If somebody has blood in the urine, then we're quicker to look in the bladder and make sure you don't have cancer or some inflammatory condition that can be causing those symptoms. But if somebody comes in and has typical symptoms and a normal urine, and they don't have a history of infection, they're not smokers, and we're not worried about bladder cancer, then usually, you know, I start to talk to people about, again, the behavioral stuff and start a medication if that's what they're interested in.
What's the price point of this Myrbetriq? Is it expensive? And is there a generic yet?
There's not a generic. So Medicare Part B covers it. And I have to be completely honest that it changes daily on which insurance companies are going to make it formulary or not. Sometimes they are, and then the next quarter it changes. It's just impossible to keep up with. But Medicare Part D is the one that's supposed to cover it most, if not all the time. But unfortunately, it can be very expensive. But it just depends on your insurance. But some people, you know, it can be $300 a month, which we do have a discount. They have provided us with a discount coupon for the first year. So that is something that we can give out to people here who want to try it at least.
Excellent. Let's see. I'm just going to stay on this roll. Guys, come on, light up the board for me. You know you want to. So, Dr. Pond, if you're currently using incontinence products like pads or briefs or pull-ups, is it pretty much, if you're using those, you pretty much have a problem, right?
Yeah, I would say once you're to that point, there's a problem. You know, and I mean, there's so much gray area in that, but I mean, for some real elderly people who have some dementia, or there's a lot of people who have some real functional limitations, and they aren't able to easily get up to the bathroom. I mean, that's a real thing. People are like, they don't move around well, and so it's not necessarily so much a bladder issue, but it's a functional issue. And again, patients with dementia don't quite get that signal that they have to go. So there's some exceptions to that, certainly. But if you're, kind of a normal, functional, healthy person, that's something that probably needs to be looked into. The other thing another reason I find people start leaking is they're retaining a lot of urine, especially in men who are older who have an enlarged prostate. So I always want to make sure they're emptying their bladder, because that can certainly be a source of new onset leaking. Various medical conditions as well. If people have diabetes that's maybe not been controlled for a while, that can cause a neurogenic bladder and cause you to retain urine. So I always do a bladder scan here as well, just to rule out urinary retention as a cause for new onset leaking. And a lot of times that's a cause. So that and obviously, aside from the simple overactive bladder, urinary retention, infections, cancer. So if you're a normal, healthy, walking around person, and you're starting to wear pull-ups, probably something you should get checked out.
Understood. 10-4. Just checking the board. Dr. Pond, we're gonna keep going. The Botox treatment in the bladder, is that injected dermally or internally?
So the way that process goes is we bring you in and we fill your bladder with lidocaine for about 30 minutes. That numbs the surface of the bladder. So this is all done within the bladder. So we just gently put a catheter in, fill the lidocaine, and let that sit for 30 minutes. Then we take that out, and then we go into the bladder with a scope, and then there's a little needle that we use to inject that medication into the bladder wall. We do about 10 injections of about 1 cc at each location.
In one visit?
Uh-huh.
And it lasts about 4 to 6 months?
Mm-hmm.
And that means asymptomatic for 4 to 6 months?
Again, they claim a 50% improvement.
Gotcha. Okay. Excellent. Checking the board. Okay. Dr. Pond, you are being asked, why did you happen to choose urology as your field of study?
Yeah, so as I alluded to earlier, I used to teach anatomy and physiology to nursing students, and we did a lot of dissection, and I loved dissection and anatomy. And so I initially wanted to be a surgeon, but in medical school, when I did my general surgery rotation, I realized that a lot of the general surgeons were really tired and overworked, and sometimes on the cranky side. This was just my experience. I'm not trying to generalize with all general surgeons.
Oh no, please share. Please share.
And so I was like, well, I don't want to be cranky and be in the hospital for 36 hours at a time. And then while I was nearing my end of my surgical rotations, I managed to step into a surgery where everybody was having fun and happy and trying to take out a kidney with laparoscopic equipment, and they were the urologists. And I thought, well, these people seem happy and seem to be enjoying their job. And so I got into it because it was a surgical specialty where people seem to be really happy with what they were doing, and it's a very gratifying field. It really is. I don't always save a lot of lives, immediately, but I feel like there's improving quality of life. I can do a lot of that.
That's fantastic. We have had a question. The question is there a difference between spastic bladder symptoms and pelvic muscle pain? And does Botox address spastic bladder?
Yeah, Botox causes muscle contraction, and the spastic bladder is kind of involuntary contractions. So, for example, I have some people who have a neurogenic bladder because they have a spinal cord injury or for various other reasons. But even though their bladder doesn't work normally, it still is spastic. and it still causes some leakage because of the spasms. So sometimes those people have a catheter anyway because their bladder functionally doesn't work, but they're still having these spasms. So the Botox really helps with that. And that's kind of, I mean, what overactive bladder is on that spectrum of the bladder just kind of contracts on its own without you telling it to. So Botox is great for spasms because it causes relaxation of muscle.
It sounds like she should look into that for spastic bladder.
Mm-hmm.
Okay.
Definitely.
Checking the board. Okay, we have a woman that's wondering. Oh, I'm sorry, this is a gentleman. And he is wondering, is it normal for a man to get up to pee 2 to 3 times during the night when you are elderly? And I'm not sure how he defines elderly.
So we call that nocturia, the getting up to pee at night. And that's a tough one. That's a really tough one because sometimes it's not a bladder or prostate issue. So when people have symptoms all day long, oh, well, yeah, all day long, I've got to go. I have to pee every hour or two, frequency, urgency during the day. I struggle to urinate during the day. I have a weak stream. Then it certainly can be within that constellation of BPH or enlarged prostate symptoms or overactive bladder. But our nocturnal urine production increases as we age. So we do tend to make more urine at night, which makes us get up more at night. Also, there's so many other things. Diabetes can cause you to increase your nighttime urine production. Cardiac issues, where especially if people have fluid volume overload. When we stand, when we sit, gravity pulls that fluid to our feet. But when we lay down flat, those fluids shift back to the kidney, and then we produce more urine as a result. Sleep apnea, as I send lots of people for sleep studies because sleep apnea is a big cause because our oxygen levels go down, our carbon dioxide levels go up, our heart releases a diuretic hormone, and it causes us to make more urine. So the getting up more at night as we age can be complicated, and it's not necessarily a bladder issue. So if it's a bladder issue, you have that issue all day. But some people go, I do fine during the day, but then at night, I'm up every 2 hours. And at that point, I say, well, we need to maybe look into some of these other problems. Is it a sleep issue? Is it other medical? Are you drinking alcohol at night? A lot of people have their nightcap. That's a diuretic. Or they have tea with dinner, and that's a diuretic. So one, stopping fluids in the evening. Two, if you have a lot of fluid that builds up during the day, propping those legs up above your kidneys an hour or two before bed. If you're on a diuretic, I tell people to take that 6 hours before bed. That way they have a chance to diurese and not build that fluid back up. So the getting up at night as we age can be very complicated. And we tried bladder medications and prostate meds and interventions, and if those don't work, then usually it's not a bladder or prostate issue. It's because of the heart or the diabetes or fluids or sleep or something like that.
Well, Dr. Pond, I know that there's a lot of people watching right now that are extremely enlightened. They are encouraged by what they're hearing. They're glad you're here. They appreciate your manner and your honesty and your candid approach. So I'm going to speak for everyone. I think it has been extremely beneficial. We are going to conclude this evening. I would like to say to the listening and participating audience, thank you from the Dare County League of Women Voters for your attentiveness and support of this league program. We do hope that your time spent with us tonight has made you a more informed, more engaged, and more healthy citizen. Please join us for future presentations and do consider your membership in the Dare County League of Women Voters. We want to thank Dr. Pond one more time. We do want to get, you're certainly welcome, ma'am. We want to thank Jennifer Schwartzenberg from the Outer Banks Hospital for facilitating this meeting tonight. We want to give special thanks to Craig Merrill. He's a League of Women Voters member, and he has special expertise in IT and technology, and he's supporting this presentation tonight. We thank him. I do want to recognize our two co-presidents of the League of Women Voters, Fran Kapanos and Judy Lotus. We want to announce that our famous League Citizens Guide is newly available at many, many locations. It's one of our favorite and most community interactive projects. It's very, very, very valuable to the community. It's just a simple phone number, fax, and contact listing, and it's famous and very helpful. So pick one up when you see these. Okay, well, participants, Dr. Pond, Jennifer, Craig, we thank you again. And at this time, we are going to conclude this health session brought to you by the Dare County League of Women Voters. Thank you, Dr. Pond.
My pleasure. Thank you for having me.
Awesome. Thank you.